So we're here to talk about the A4 study, or the anti-amyloid treatment in asymptomatic Alzheimer's disease study. It's a landmark study because it's the first time that an anti-amyloid agent has been given to people at risk of AD to prevent the onset of symptoms and before any of them are in place. We're the largest and only site outside the US and Canada, and we're doing it in cooperation with the Austin Hospital and Heidelberg Repat. Our PI, Colin Masters, who makes his apologies for not being here today, he's on the steering committee for this study. He's devoted 40 years of his working life to studying Alzheimer's disease and trying to find a cure. The study, I mentioned that we're doing this in cooperation with the Austin and the Repat. You've all seen the information sheets which describe the various phases of the study. The way it works once we make an appointment for you is that you'll come in here, first of all, for a cognitive assessment because we're looking for people who fit within certain parameters and are normal cognitively. If you fit within those parameters, then you'll go on to have a medical history taken, physical examination, neuro examination, ECG and blood tests to make sure that you're physically healthy and it wouldn't actually cause you any harm to participate in this study. If that's all good, then you'll have a PET scan which is done at the Melbourne University and we're looking for people there who have evidence of amyloid in their brains. If you have evidence of amyloid in your brain, we'll be telling you about that and talking more about the risks. And following on from that, you'd have an MRI scan, and that's at the Austin Hospital, and that's to make sure that there's nothing happening in your brain that we would upset by giving you an anti-amyloid agent because, you know, we want to make sure that you're all safe in doing this study. And then following on from that, there'd be 4 weekly infusions of the anti-amyloid agent, which is called solanezumab, or placebo at the Repat Hospital. And we would visit you there every 12 weeks to do a cognitive assessment, and every 12 months we'd do the full range of everything that happens at this screening time. So now, to talk about things more serious, I'll hand you over to Professor David Darby, who's our lead clinician on the study. David is a behavioural neurologist and he has a special interest in the early detection of cognitive impairment. David.
Thank you, Marie. So,
questions at the end. Sorry, I left out.
So my job is actually to enthuse you, to make you aware of the current state of the play of this field, which... Sorry? Do we get a T-shirt? No, we wear the T-shirts. And to actually tell you how buzzing and how exciting this area is at the moment. So I think you're actually all very smart getting in on this sort of trial, which, as Marie says, is the first of its type in the world. I actually think you're pretty smart because the treatments are looking like they're working, and more about that a bit later. So if you can get into these trials and get onto these treatments, you know, you may never get Alzheimer's disease again. We're actually beginning to think about this. So I wanted to give a background about the work that's been done in this area so that you understand a bit more about these terms, amyloid and Alzheimer's disease and dementia, these sorts of things, because they're often confused. So there's actually been quite a lot of advance now and advances in Alzheimer's disease, particularly over the last, let's say, 20 to 30 years. But it's been particularly important to understand how Alzheimer's disease develops, and that's where this protein called amyloid protein comes in. So just a few minutes on what amyloid protein is. Amyloid protein, the term amyloid actually means a protein that tends to aggregate with itself. It seems to like itself enough to bind with itself and then to form larger molecules of 5 or 6 of these amyloid protein molecules together. And it turns out that these soluble molecules, when they've joined together particularly, they can float around in the brain and they can embed themselves in membranes. Now the membranes of the brain are particularly specialised for transmitting communication between nerve cells in what we call synapses. And these amyloid molecules tend to bind in the synapses, and they interfere with the communication, the chemical communication that's going between those two membranes in the synapses. That then can lead to poor communication between cells, and it can lead to symptoms. It can also lead to destruction of those synapses, so they actually get destroyed and disappear. So then the brain has to try and repair them. So that's what we think is going on now with the amyloid molecules. The amyloid molecules also congregate and aggregate into much larger, hundreds of thousands and millions of molecules together in what we call plaques. Now these plaques have been seen for over 100 years now under the microscope, and they seem to be sort of warehouses for this amyloid. We don't think that they're particularly toxic to the brain. We think they're just storing up this excess protein. And it turns out that now, over the last 10 years, we've been able to work out how to image those in living brains. As you probably know, in the past, we could only make a diagnosis of Alzheimer's disease by symptoms. There was no actual definitive way of knowing that a person who had memory problems, for example, actually had Alzheimer's disease until they either gave us permission to do a brain biopsy or a post-mortem. And by the way, neither of those are we proposing to do in this study. And then what you'd see is, under the microscope, you would see the pathology of Alzheimer's disease as described for many, many decades. And that would include those plaques and also other features as well. Now, over the last 10 years, one of the big advances has been the ability to image the amyloid protein in living brains. And this is where you guys come in. So, we've only over the last 10 years been able to do it. A lot of the work to understand what happens with those proteins has occurred in this town. There's a study we call the Australian Imaging Biomarkers and Lifestyle Study, or ABLE for short, because it's a mouthful. The ABLE study has helped us understand, by using the amyloid imaging, how it develops and how it increases and who we can see it in. And it turns out that it's probably present up to 30 years before people have significant symptoms of Alzheimer's dementia. So now we have this window to try and detect people who've got Alzheimer's disease. It's not dementia, because it's not bad enough to cause those symptoms, but hopefully at a time that's early enough that some treatment by removing that amyloid might actually do something in terms of preventing them from going on to getting further damage. There are trials at the moment that are being done at all stages of Alzheimer's disease. We have been quite disappointed with the results of those that have been done in people who have established Alzheimer's dementia, and we think it's because we're treating those people too late. Now, we like to give, as in that information sheet, there's an analogy to the cholesterol story. So we like just to clarify that for you. People in their 20s or 30s who have elevated cholesterol usually don't know that they've got elevated cholesterol, because it doesn't cause any symptoms. But at some stage, the cholesterol seems to narrow the internal lumen, the internal tube of the arteries, particularly in the heart and the brain and other places, and at some stage that can then block, and the person might get a heart attack or a stroke, for example. Now, when that happens, lowering the cholesterol, it may prevent future heart attacks or strokes, but it doesn't really do anything useful for the established damage that's already occurred. And we now think that the same thing might be happening with the amyloid, that it's initially deposited in small amounts and it may do a bit of damage, but the brain says, I can cope, and it compensates. But then maybe 10 or 15 years later, the brain can't compensate as much. Maybe it's lost too many synapses, it's not repairing itself as well, and other things start happening and the damage starts occurring. And when that happens, you start getting symptoms, particularly very mild memory loss as some of the initial symptoms, some of which we know is actually reversible if you can treat that very early. Then it tends to get worse, and if it gets worse, eventually you might get the symptoms of full-blown dementia. So that is now the recognised disease. It's a spectrum, a continuum from nothing except pathological changes with a bit of amyloid, all the way through to established dementia. And I usually say here, dementia, what's dementia? Because a lot of people perhaps get this concept a bit confused. We use the term dementia to mean a syndrome. So this is somebody who has memory and thinking problems who's not able to cope independently. That's just a snapshot of it. So you can understand that as a neurologist, I recognise multiple causes of that. Alzheimer's disease is by far the commonest cause, but there are many, many other causes as well. So it's a bit like having abdominal pain. It could be due to an appendix that was inflamed, or a gallbladder, or bowel obstruction. Lots of different causes, but the overall term is abdominal pain. Dementia is the same thing. So we are now trying, therefore, to move the detection of the Alzheimer's disease earlier and earlier. As I said, there are studies going on now in people with established dementia, but there are also studies going on in people who have just very mild memory problems. And the exciting news is that about 2 months ago there was an announcement at one of our conferences of an antibody treatment similar to the one that's being used in this particular study, with a very long name called aducanumab, which was reported to both remove amyloid in people with mild memory problems who had these positive amyloid scans. So they had amyloid in their brains in excess. This antibody removed that, not completely, but it did remove it from their brains significantly. And over about a year, there was a plateauing, a flattening of the decline that was seen in these people compared to those who were still on placebo treatments. Now, I don't know whether you find that absolutely invigorating, but that's such an optimistic finding for us. It's an early study, and we hope that there'll be more announcements in the next few weeks as well, including at a conference that Professor Masters is going to next week in Washington, where the solanezumab is being reported. Some findings are being reported on that. Now, we've got our fingers crossed that it will also show that there is a plateauing of the decline. And again, if that happens, it means that it's not the drug itself that's important. It means it's the approach to treat people early and to remove the amyloid at that early stage. Now, so that gives you a background, I hope. Now talking about this study. So as Marie said, this study is the first of its type. It's a very innovative and ambitious study because for the first time we're asking healthy people who have no symptoms. They may have concerns, that's different, and they may have family members who've had Alzheimer's dementia or disease, which is horrible, but is very motivating in some ways. We're asking healthy people to front up and to potentially be told that they are going to have a very high risk of going on to getting Alzheimer's dementia if nothing is done, because we haven't done this before. We are going to be screening people about the age of 65 and above because we know that at that age, from studies like the ABLE study, that about 35% of people that we take off the street, and to qualify that, people who would volunteer for studies who we take off the street, and that's sometimes said to be a rather intelligent and unique group. And we're going to then scan them, assuming that they're eligible on medical and other grounds, and tell them that they either have a high risk or they don't have a high risk for going on to getting Alzheimer's dementia. That is previously unheard of, doing that sort of thing. So we're a little bit cautious. One of the things which we are doing is we're going to be asking you several times about how you feel. A bit touchy-feely, but we're going to ask how do you feel about, being told this information, about having the scans. When you're told the result, how do you feel now? Those sorts of things. And it's, again, something that we're just being cautious about because we're not sure how people will react to having this information. In general, I have to say, our experience has been very positive, that people actually want to know, and if they are found to have amyloid in their brains, they generally are very keen to do something about it. Not surprising. So, the study itself, and I've got some notes about it, but the study itself has 2 phases. The first is a screening phase of about 90 days, and the aim of that screening phase, we think, is to exclude you. The scans are quite expensive, and probably the most expensive part of the study, so we don't really want to do them unless you are eligible for the treatment phase. So, as Marie said, we'll do a few things on the first day here, memory tests, other things, just to see that you're not too good in your memory, believe it or not. Because if you're too good, we can't measure anything but a decline. And we don't want that. We want to be able to measure both changes, getting a bit, because everybody has bad hair days and good days, so you vary a bit. Secondly, we know that people who have a bit of amyloid in their brains tend to perform a little bit worse in the healthy range. Still within the normal range, but just a little bit worse. So we're trying to hedge our bets a little bit and pick people who are in that range. If you're worse than that, and we have occasional people who come along with concerns who actually do have memory that's not so good, then you won't be eligible either, because the trial has a treatment phase of 3 years. And we don't want to treat you for 3 years if it's clear that you're going to decline quite dramatically in that period of time. We think 3 years is ethical for people that are healthy and without symptoms, but we don't really think it's ethical for people who already have significant memory problems. They need to go into other trials. So if you pass the screening phase, then you then go along to the scans. And I just wanted to mention a few things about the PET scan. The PET scans, they involve a little bit of radioactivity. It's an antimatter bit of radioactivity, so it's actually positrons. So if anyone's a science fiction fan, this is Star Trek stuff. And the positrons are bound to a dye, and that dye is what can cross the blood-brain barrier, as we call it, the barrier into the brain, and can then attach to the amyloid plaques. We can then see it. So the scan involves about an injection and about 20 or 30 minutes of letting it bind to the brain, and then there's about a 20-minute scan when you just lie there and think a pleasant thing. That scan will then be reported, and we then can determine whether you're eligible or not. On the basis of that, there's a threshold above which you're regarded as being eligible, and above and below which you're regarded as not being eligible. And that's been determined based upon the risk, either high or low, of then going on to getting Alzheimer's dementia in the future. About the only side effects of that PET scan are the radiation, not surprisingly. It's about 3 to 4 times the background radiation you might get in a year. So we don't think it's a lot. We think it's ethical to do that. The other one is if you've got grandchildren, and many people here have, please don't, thank you for that show of hands, please don't cuddle them for 24 hours or so. All right, so you've got to get your spouse to do that, or someone else. Right, so if you get through that and you're eligible, then the next phase is the treatment phase. And the treatment phase is 3 years, as I've mentioned. Now, the treatment, solanezumab, is an antibody. And antibodies last for about 7 months in the body before they totally disappear. Why is that? They have what we call a half-life of about 28 days. So every 28 days they drop by a half in their concentration. So the treatment, to keep it topped up, is to give that to you every month. And that keeps it up. If you have on your bucket list a couple of holidays, maybe some grey nomads here, I don't know, to go away for a little while, you can miss 1 or 2 doses. That's not a major deal, because you can see that there'll still be antibody in there. But generally, it's a bit of a chore. Once a month, you come down for your treatment, which is at the moment done at Heidelberg. The side effects, let's talk about those briefly as well. So in general, the antibody treatments have been very safe, and we've been surprised at how safe they've been. There have been over 100,000 doses given of this particular antibody, and we're all watching very carefully to see if there are any significant side effects. As you were told also, each person will have a 1 in 2 chance of being on the active drug, the solanezumab, which is given in normal saline. and if you're randomised to placebo treatment, then you'll just get the normal saline. There are obviously potential complications of putting a needle in. We try and have very experienced people, so that's not a major problem, and we do it under appropriate sterile conditions, etc. But the one that we worry about perhaps most is because we're giving an antibody that's removing amyloid from the brain, there is also amyloid in the small blood vessels in the cortex. Now, in Alzheimer's disease, normally we see that. There is amyloid in blood vessels, and that can occasionally leak. And if it leaks, you can get either fluid, which we call edema, or it can leak red blood cells as well, which we call hemorrhage. Actually, we call them usually microhemorrhages because they're so small. In people with Alzheimer's disease, we see those microhemorrhages more commonly than we do in people who don't have Alzheimer's disease. So it's a sort of a marker of that pathology sometimes. The treatments can also cause that. We think they do it by making the small amounts of amyloid that's in the walls of those blood vessels move out, and it makes the blood vessel perhaps a bit more fragile. So you can get fluid or you can get hemorrhages around there. Now generally, the vast majority of those we have found are without symptoms. So they just occur. So we do MRIs relatively frequently throughout the 3 years just to see if there's any evidence of those. And if there are, we then stop the treatment until it resolves on MRI. And it's been shown to be safe then to continue treatment. Occasionally, and it varies depending on the antibodies, but occasionally they can be symptomatic. If they're symptomatic, the sort of symptoms that you get are things like headache, not surprisingly, or you can get dizziness or faintness, things like that. Now most of those things the participant themselves will notice and they can report them to us. But occasionally people get confused. And you can imagine if somebody gets confused, they may not know they're confused. And so we do need to have, and this is, in my opinion, the major reason we have a study partner or a person responsible who is then involved as well. And it's really their job to sort of keep their eyes on the person who's participating with the treatment, just to see if they notice anything that should be reported. Now, we're also dealing with, unfortunately, a relatively older group of people. So there are risks of other problems occurring by natural causes. What we have noticed is that there doesn't seem to be any difference in those sorts of things between people on placebo treatment and people on the antibody treatment. Things like heart attacks or strokes or death for other reasons. A bit of a fact of life, unfortunately. So, at the end of the 3 years, the trial will finish, and we are currently in negotiations with, but it's very likely there will be an extension trial, which means that everybody who participated will then be put on the active medication. Now that might change. For example, if during the study the Safety Monitoring Committee recognises that there's a serious problem with the treatment and it's causing serious effects that the placebo doesn't, they'll obviously stop the trial. On the other hand, if they notice that the treatment is vastly superior to the placebo, they'll also stop the trial, and then everybody will be offered participation with the actual treatment. All right, and the whole world will celebrate along with you. Right. Now, they're the major things that I wanted to talk about. I do have just a couple of almost housekeeping things, and maybe you've done these, but have you all given your names to the clipboard to Rebecca at the back? Okay, so if you have, that's great. If you haven't, or you've just come in, then you might do that on the way out, particularly if you're interested in having an appointment made so that we can then do the consent form and then start the process. If you are not so sure that you want to be involved after hearing this now, then there are also cards of Marie in particular, which you can take, think about, and then get back in touch with us about that if you decide to be involved. And that's, I think, all I needed to say. I don't know, I missed something?
Are there any questions?
Yeah, any questions? Thank you for your attention
I've got
too.
a question. I think you've answered. You started off calling it Alzheimer's dementia, and then you explained that there were other forms of dementia, and then you came back to calling it Alzheimer's dementia. My history is my mother, my maternal grandmother, and my mother's two sisters all have vascular dementia.
Right.
Same?
No. So vascular dementia is regarded by us as a different type of dementia. It's a very complex dementia. There are lots of aspects to it. In general, as we get older, there's a bit of wear and tear in our brains. If you have vascular risk factors, then in addition to that wear and tear, you can get blockages or damage to small blood vessels.
Right.
And so you can have some changes. Now, some of those changes are really very common, and they're not a reason to exclude a person from this trial. But if somebody actually has a blockage of a blood vessel that causes a stroke, so that's something that we can see on the MRI, for example, then that is a reason that that person would not be eligible for the trial, for example. Because strokes can cause deficits in thinking and memory, and then we wouldn't really know, whether or not that was something that was contributing to perhaps some changes that occurred over time. So, and having said that, vascular changes are very, very common as we age. So it's something some people say that people with Alzheimer's disease actually have almost universally, at least microscopically, vascular changes.
Well, that's what we were told about my grandmother.
Yeah.
That they said really she has a combination of both.
So the comment was that her grandmother might have had a combination of both. So that's actually quite common. But it's not a reason, if we're treating Alzheimer's dementia, to not treat them. We do tend to treat dementia. Remember, we're not talking about that here. None of you guys have got Alzheimer's dementia. Put your hand up if you have. Okay, no one did. Any other questions? Oh, someone did later on. Okay. Maybe we'll go around this way.
Okay. You can probably answer the three questions.
Okay, then you better give me one at a time. I may not remember.
You mentioned before about the half-life. Now, and is that the solanezumab treatment you're talking about?
Yes. So solanezumab.
Yes.
And you can practice that in front of the mirror if you like.
Yeah,
Solanezumab is the antibody, and all antibodies in our body get manufactured, and they have a half-life of about 28 days. They're taken away by the spleen and by lymph nodes and other sorts of...
that's what you're talking.
Yeah.
The other with the F18 radioactive substance.
Yes.
Now, is there any long-term promises when they do the PET scan? I believe, isn't it? It's injected. That one and.
Oh, that's the question too. So the question was long-term side effects of having the labelled glucose scan. So the positron emitters that we use have half-lives of the order of minutes. But it basically means that they disappear completely within about probably 6 to 8 hours. The 24 hours is usually just to be certain, that's all. So short-term effects, they're giving you a bit more radiation than you would by just walking around in the world every year. So about 3 to 4 times maybe that. In terms of long-term side effects, well, we don't really think there are any. But that's probably as accurate as I can be. Because, yeah, it's one of those open-ended questions. It's certainly not enough to cause thyroid problems or the sort of things that you see in survivors of Holocaust, nuclear Holocaust, for example.
Yeah.
And number 3?
Sorry.
So we're not coming back to you, by the way. This is your 3.
It seems to be, when I read the sponsors all seem to have all care but no responsibility, the way I see it. So
okay.
It does say about guideline for compensation. So how does that work out? If there really is, after 3 years, really gone downhill and blah, 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 what's the process? Because as we know what happens, people investigate themselves and find nothing wrong, it's a cover-up or whatever. So just...
Wow. I've never had that question.
It's standard wording.
Yeah.
That stuff is on the information sheet. It comes from the Department of Health, and it's standard. Sorry,
it's standard wording that needs to be included in the information sheet. But the study is indemnified by Eli Lilly, who are making the drug. They're only donating the drug. They're not giving us any money, but they're giving us the drug. So if you were to have any long-standing ill effects because of their drug, they would need to compensate you. And I think that's in the form.
Yeah, so we can actually, we can ask for the guidelines, what they, is it a 100-page document?
That's right. Yeah. That's your fourth question.
Someone else has to ask that one as well. Right. No worries. Okay.
Yes, you can.
Next.
I'm sure if we went around here, we'd find that just about everybody will be away, either on cruises or holidays, you know, anywhere from 3 to 6 times a year.
Okay.
How's that going to work
Do you want me to
out
take
with
that
this?
There's a 10-day window for visits. Take that back a bit. David mentioned that there's 90 days for the screening period from the first time we see you here and the first visit at the repat. We'd like that you'd be in the state for those 90 days, or perhaps only interstate for a weekend or something. Once you're actually on the study, we have a 10-day visit window for visits. So if you were to go away for 5 weeks, we could conduct your visit 7 to 10 days later, and that'd be okay. There's also provision if you wanted to go away for 2 months, that you can miss an infusion, or you can miss 2 infusions, up to 2 infusions in a row, and you can miss 7 over the course of the 3 years. So there is something in there to enable you to have a holiday, wherever you like.
And 6 times a year, you said, wow.
It'll be all right, wouldn't it?
I know. Lucky guy. Next.
Will there be a calendar of dates that we can work around?
Yes. Well, again.
Hello, camera. Once you get to the repat, the visits that we'll arrange from here, they'll be mutually convenient. We'll be able to work them out on an individual basis with you. Once you get to the repat, they can put your start date. The baseline is sort of called week 0, and that'll project the future visits for 3 years, and they'll be able to give you that then. Okay.
Now we're moving over to this side.
I'll stay here.
Yes, we'll maybe come back. This side, yes, please.
Could you give me an idea how the antibodies are produced? Because there has been some danger in earlier production.
Well, my understanding is these are humanised monoclonal antibodies, so they're produced in sterile conditions with. Actually, I don't know whether it's using animals at all. Actually, I can't answer that. We've got Chris here. Does he know? No, I don't know either.
It does say animal or human in the notes.
Animal or human what?
Animal or human
antibodies.
in the production of it.
Yeah. Well, perhaps we could take that on notice, because I don't actually know the answer. I know they're humanised. That it is a trend to try and not use animals in the production of these, and one of the other antibodies which I mentioned recently, that doesn't use animals at all. So, but I can't answer specifically for solanezumab and how.
What does humanised mean?
It means they don't have any antigens that are going to cause. So they don't have any components on them that might be animal proteins that might cause problems. So they look to the body, human body, like they're made by humans. Does that make sense?
Like
So the question was, I'm sorry?
Mad cow disease or that?
No. They don't look like mad cow disease is from a protein changing its conformation. It's different. Now we're going down this side. Heaps of them. Yes, gentlemen?
Some of us, I should imagine, who don't have any partners. What is the situation in that regard?
I'll let you do it, Ian.
Yeah. Unfortunately, we can't participate in the study without a study partner. We need somebody for...
Yep.
You can't participate in the study without a study partner. We need an informant to tell us about the sorts of things that you do at home, so that that information can then be used to question you. And also, as David was saying, because you know, sometimes confusion or headaches occur, we need somebody else to feed that information back to us so that we can record any ill effects.
So, if I can follow up with that. So usually if people don't have spouses, then they'll usually designate either a friend or a child of some sort that is able to sort of vouch for the fact that they're looking on you reasonably frequently. So there are usually other solutions, but sometimes you have to be a bit innovative in the way you source your friends and your circle, your inner circle. Does that make sense?
Yeah.
Yep, okay. Next, yes, sorry. Gentleman was next, sorry, ladies next.
Two fairly practical and pragmatic ones. How would the study affect someone who's a blood donor? Would you carry on as a blood donor?
Yeah, so there are a couple of things that raises some good points. Because you're being given an antibody there are a couple of things. This is an experimental medication. We really shouldn't be donating blood from those people to other people who then might inadvertently get it, who haven't consented to this trial, for example. So, no, in general we do ask you to refrain from for the period of the trial from blood donation. And similarly, I don't know whether it's an issue here, but we are a bit paranoid in the same way about pregnancies and things like that. If anyone's interested in getting pregnant again, please don't do it during the study. Well, hold on a second. Yeah,
the question of the study partner, are there visits in the treatment where it's not safe, like in my case, to travel alone? Walk back to the station, catch the train home, that sort of thing, after receiving a treatment? No,
I don't think so. I mean, I've been involved in giving this particular infusion multiple times now in other trials, and people make their way there and home afterwards.
So
clearly
it's okay to drive and all that sort of thing?
Yes, it doesn't make you drowsy or anything like that. The conversation might make you laugh with the nurses, but apart from that, it's usually not too bad. Now, we had a lady who's jumped in the back, yep.
Sorry, I have two questions. Can I cuddle my dog?
Can you what?
Can I cuddle my dog if I can't?
After the PET scan. If it's a puppy and you want it to breed, then I would suggest not. So that was a joke. Okay, next one.
No, it was a sort of a joke.
Yeah.
My next question is based on the study, the 1,026 people who had had long-term injections, and the list of the more serious side effects that they experienced. They're in the notes, obviously.
Yep.
I mean, I can read them out because they sound quite scary.
Yep.
But they also sound a little bit unrelated.
Yep. That's right.
Like, swollen eyelids and
yep.
emphysema. You wouldn't think they're going together. But it's the issue of things like inflammation of the joints and bruising. Is there any evidence, or was there any follow-up of those particular people to know what the causes of those things were finally?
So, being involved in these studies, it's my observation that most of those are, as you say, idiosyncratic, which is our term for meaning that they just happened and so they had to report them. So I don't think there's no systematic report of side effects that are more than placebo. There are some things like fainting and perhaps a bit of low blood pressure, which are probably related, we think, to the swelling and maybe the microhemorrhages in some people. But in general, I'm not aware of any other of those side effects which don't also occur in people with placebo treatment, and also basically just part of the full disclosure that the company has to do.
And all those people had Alzheimer's disease, which I've known.
That's true. So all the, Marisa said that all the people that had, in that study already had Alzheimer's disease, much more marked than you guys did. So, so it's also, the older it's true that people with Alzheimer's disease are older than probably most of you, I guess, but in general, and so they are more prone to getting other diseases as well. Okay, so now we're at this lady again. Please, hi.
Yes, you may have mentioned this, and I've got your cut. But all the medical tests that are taken early on, do we get the results of those tests, or our GP?
Most of the tests that are done will come back normal. We scrutinise them. If a test is abnormal, then we have an obligation, an ethical obligation, to make sure that that's reported to your GP or whoever. We usually report it to you so that you know, and then to follow up. If there are costs associated with that, then particularly during screening, if it's something that we pick up, say in a blood test which is abnormal, that would then be your responsibility.
I understand. I wasn't meaning that. I was just
Yep.
having all these.
And I'm not paranoid about the cost either, but no, definitely. That's, for example, if you have an MRI and it shows an unsuspected cyst or something, we obviously have to tell you about that, and then you would follow through with appropriate investigations. Yeah, no doubt. But we don't routinely tell you all the results of all the things that we do.
So no news is good news.
Yes, that's the way I look at it. Yep. Now there was one here. No. Okay, we're going to go back again. Lady at the back, and then you.
Where's the funding come from?
Well, Marie can answer that in more detail, but my understanding is that Risa Sperling, who's the principal investigator in Boston, she organised funding from NIH for the American side of it. So the National Institutes of Health, that's put in a lot of money. The pharma company Eli Lilly has put in some money.
No, they haven't put any.
No money at all?
Only drug
Okay.
and tracer.
Okay, so is there any, I thought there was pharma that was in it as well. Because I thought she had a consortium, that's all. Okay, I've got that wrong. But there's philanthropic donations as well. So people have donated money, wealthy people. Now here, we've managed to get some NHMRC funding, and also some philanthropic funding as well, I think is the way Colin's done it. So Colin's predominantly funding it here. Colin Masters, yeah. Now, yes?
Who are you targeting this drug at? Will it, if it's proven to be effective,
Yep.
who would be the recipients?
Yeah, that's a really good question. Okay, so you're asking me to look into a bit of a crystal ball in the future.
Well, I'm just thinking we are hopefully pre-symptomatic.
Correct.
How would you find,
Yep.
Is that your target, and how would you find those people?
Okay, so good question. So I mentioned the Australian Imaging Biomarkers and Lifestyle Study, or ABLE study. That's one of the studies which is being done to try and help develop a database of people who are well characterised in terms of their amyloid status, for example, in their brain, and blood tests, and some of them have donated spinal fluid as well. What we've already learned is that there are changes in the spinal fluid. So if spinal fluid collection, also called lumbar puncture, becomes more acceptable, that may be one way to not have to then do amyloid PET scans. What we're hoping, that being able to collate all that information, we can actually work out some blood tests that will work. So, assuming that we can do a blood test, what we assume will happen in the future is that people from about the age of maybe 40 onwards will have a regular blood test, just like they now have here fecal alcohol bloods done 50 years of age and above. There might be something like that. Then if that's positive, there may be some false positives, we don't know. They might then have a secondary test like an amyloid PET scan. And if that's positive, then we assume that in a world with a government that can fund medical treatment, there may well be then treatments. We assume, in the way things are going, that there'll be what we call an induction treatment, which might be like this solanezumab antibody, which removes the amyloid. And when it's all removed, we then assume that there'll be a maintenance treatment of some sort which will stop the production of the amyloid. And there'll be regular surveillance in the way that you do with cancer or other sorts of chronic problems like that.
The government would have strong motivation to do that.
The government would have strong motivation to do that. I'm going to quote you.
They have to spend so much money on people with Alzheimer's, that's what I'm saying.
I'm still going to quote you, because I think that's a great thing to pass on to our neighbours.
I'm talking of a lot of people.
Well, Marie's just said that you guys are the baby boomers, and you'll be the biggest voting group in Australian politics, so an election. So there we are.
Our Prime Minister et al. Can't come.
So let's not talk about specifics, because this is being recorded.
Is the same study being conducted anywhere else?
We've got I know it's getting disorganised now. Is this same study
being conducted anywhere else?
Right, so the only 2 places in the world are in America, where there are multiple sites, and here. Okay, we've been involved because we basically put our hand up and said we want to be involved. You know, Colin Masters has done a great job in that way, as have other people involved in the ABLE study. So we've now got a track record here in Melbourne of being very good at Alzheimer's disease and neuroscience, and we're very proud of that. And you know, we've set up these sorts of infrastructures in order to do just that, to try and help.
I mean, with the same indicators.
Yes.
Because you said that there've been tests on people who are advanced.
Oh, I see what you mean.
With the same indicators, the same group that you're testing here, what I'm getting at is, have tests been, or are they being conducted elsewhere, and how far along are they?
Okay, that's a very long discussion. There are, I think, 16 trials that I know of going on at the moment in a whole range of...
With the same target group?
A whole range of severities of Alzheimer's disease, and some very early, few. This is the only one in healthy asymptomatic people. There's no other one being done at the moment. There are a few trials being done in people with milder memory problems than dementia, and a few in early dementia as well. So, and they are being done not only just here, but also in America and Europe and other parts of the world. Yep, everyone's pulling together to try and get a treatment for Alzheimer's disease. So hold on, there was, one up the back. A new face? Yes?
Did you say that if there's no amyloid detected, then you're not eligible, or does everybody have a little bit?
Okay, so the study will say that to us whether you're eligible or ineligible. They don't tell us what the score is. Okay, so we know that there is a threshold above which they will say, you could consider it automatic, that they'll say you're eligible. Now, below that, you could have no excess amyloid in your brain, because there is some non-specific binding that we do see even in 20-year-olds in what we call the white matter, not the grey matter. And so you could have that appearance, in which case your risk of getting Alzheimer's disease is very, very low in the next 20 years. You know, maybe less than 5%.
So then you would be eliminated.
Correct. There's no point treating you if you haven't got the disease. If you're above that threshold, well, if you're not no amyloid increase, so just a bit above that, but still below the threshold, then we estimate that in the next 10 to 20 years, your risk is very low, of the order of, we say 5 to 10%. We would like those people, though, to consider being involved in our ABLE study, though, because it's through those people with a low risk that we can work out what the blood test might be. And remember, we think we're smart, but we're not that smart, and there may be a smarter test that comes out in the next few years. If we have samples from people like yourselves, if you're well characterised, we can just go back to those samples and hopefully rapidly work out whether or not that new blood test works. So there are lots of reasons. We don't want you leaving here without being in a study, in other words. Yep, please. And then also, then you're
from what you've said, I understand that the amyloid as a substance is always in the human body?
So...
and I'll just follow that by saying,
yep.
If it is there evidence for what triggers its expansion or growth?
Yeah, okay. So both very good questions. So amyloid, yes, it's present in all people. It's a byproduct of the breakdown of a larger protein in the brain, this particular type of amyloid. Most commonly, it's not even created. It's actually split in half and it doesn't occur. But for some reason, and this is where we get on to we don't know, but for some reason, in people who are destined to get Alzheimer's disease, you get more of that produced, and it does accumulate. Now, so just to mention this, in people who have a family history of Alzheimer's dementia, where it starts in the late 30s and the early 40s, right? So we have people in that group. They are the sort of people that have informed us a lot about Alzheimer's dementia, Alzheimer's disease, and the amyloid protein and what happens. So if you look at what happens with their mutation, so those people tend to have a mutation in a gene, some of them, if not the majority, but some of them if it occurs at that age. And the mutations tend to increase the production of the amyloid protein. So if the amyloid protein is in a larger protein, it tends to snip the larger protein so the amyloid protein is produced in excess. And so that's why we think they get it early on. There's also one Icelandic family which has been described that has a mutation that cuts the amyloid in the middle of the amyloid protein. So it cuts the larger one in the middle. So the amyloid protein is almost never made. They don't get Alzheimer's disease. What a family, eh?
Yes.
Yeah. Find the offspring of that family and marry into them.
There'll be some advantages from living in Iceland.
In Iceland. Must be some advantages, yes. And the only other thing to say about that is that we do know that patients who have Down syndrome, for example, so Down syndrome has an extra copy of the gene on which the larger protein sits, they overproduce amyloid, and they tend to get changes of Alzheimer's disease almost universally by the age of 50. They're the major points, I guess. So we don't currently know why people with sporadic Alzheimer's disease actually trigger that cascade of too much amyloid. We're still looking for the reasons. And it is a disease because not everybody gets it. The other thing which happens, which I was going to say, was the rate at which it's deposited clearly varies. If you have a gene mutation, it seems to deposit quite rapidly and early on. Some people who don't have a gene mutation do get it earlier, in their 50s or 60s, with the average age of Alzheimer's being about 70 or so. And we've now begun to understand a bit of that. There are certain genetic mutations, changes, which, if you're going to get Alzheimer's disease, accelerate that. One is a thing called the apolipoprotein E, which is a cholesterol-carrying protein in the blood, and that has particular variations, some of which increase the rate of production of amyloid. There's also other genetic factors which seem to do that too. So we're beginning to understand a bit about that, but we still haven't worked out exactly why people with what we call sporadic Alzheimer's disease actually, why it's initiated. Colin's working on that. Okay, now, please.
Okay, well, you've answered some of it, but I wondered, given that we've known about this disease for a long time, whether there's any evidence to suggest that it's more predominant in particular cultures or parts of the world, or whether it's the Western world, or whether there are some sort of protections depending on where you
Yeah, okay, so asking about risk factors, yeah. There are no geographic protective factors apart from that one family in Iceland that we know of. If people live long enough, they will manifest as a population Alzheimer's disease.
So is it predominant in Japan, for example, where they do have
Well, it's actually the second commonest cause of dementia in Japan. Vascular dementia or vascular cognitive impairment is much more common in Japan for some reason. It used to be the salt that they had, it used to be the... Sorry?
But that's quite strange because their diet is so much better than ours.
Ooh, their diet's so much better than ours.
I think so. They live much longer.
Well, it's funny because one of the protective factors in terms of diet is a Mediterranean diet.
Yes.
Actually, so better is a relative term, madam.
They do live longer.
But that is one thing. So geography, no, but specific lifestyle factors, yes, there are some factors. And I almost always get this question about, cognitive stimulation, brain training, all that sort of stuff. But so exercise is the other thing. So people that do exercise more, particularly intense aerobic exercise, actually tend to slow the rate of progression if they've got mild memory problems. Brain stimulation, there is no evidence, I'll say this on record, there's no evidence that it can slow the rate of progression of someone who's got Alzheimer's disease. There is evidence that in healthy people without Alzheimer's disease that certain forms of brain training seem to be able to transfer or generalise to other forms of thinking, but it's in a very small group of super healthy people that that's been shown. So There's still, that jury's still out, I think, in terms of whether or not it's worth spending your money on lumosity or the ADC program, all those things, yeah. Which is ours from the Florey, by the way. Active memory, if you're thinking maybe that's the better one. All right, so a couple more, maybe two last questions. Well, you've asked one, can I leave to the end? Yes, please?
I just wonder, I've heard somewhere that people who have been using the drug for cholesterol, it has minimised the progression of Alzheimer's, is that correct?
Okay, so there was anecdotal, and by that I mean there was a suggestion of evidence that that was the case. And about 15 years ago, I guess, one of the drug companies did a very large study around the world, specifically trying to treat people with Alzheimer's, mild Alzheimer's disease with, it turned out to be Lipitor, with one of the drugs. There was no benefit of doing that in people with established Alzheimer's disease. Now, whether or not taking it at this sort of stage, when you're asymptomatic or not, we don't know. Okay, we still don't know that. We have some theoretical evidence, obviously I could talk about these things forever, but anyway, we have some theoretical evidence that when you have too much cholesterol in your blood, that your neuronal membranes are a bit thicker. And that has been reported to be associated with a change in the metabolism of that precursor protein of the amyloid to tend to cut more of the amyloid rather than less. So it may or may not all be related. And you would think that by dropping the cholesterol in your blood, that you'd shrink those down and then favour the non-amyloid pathways. But still early days, we don't know that yet. Now, I want to say, we had this lady here.
For some reason I had a brain scan and was found, outside the study, and found that I did have amyloid. Are there any drugs around today that would treat that?
Okay, so that's not so theoretical anymore, actually. It's the issue of private amyloid scans and whether or not having an amyloid scan that, say, you pay for determines that you do have amyloid, or you might have a spinal fluid study and it shows that you've got the changes that suggest that you might be going to get Alzheimer's disease. Can you do anything about that? Well, at the moment there are no treatments outside of research studies. Standard treatment for somebody, let's say that your amyloid is elevated, standard treatment for you at the moment is nothing. I've talked about some of the lifestyle things, but there's no other treatment that we know of. So the issue of private amyloid scans, that's actually one which will be hitting us as medical people in the next month. They are going to be available here at the Peter MacCallum Clinic probably, Peter MacCallum Hospital. You've got to have specific indications for it, but people will be able to pay for those for about $2,500 or something.
So not public patients?
Well, probably the worried wealthy, we call them. Last question, this gentleman. You've had a good go.
Well, do you want me in the study or not?
Well, hold on, can we talk to you afterwards then? Well, all right, sorry, last was a follow-up, right? Please.
If I do go in the study and it gets found out that I have got amyloid and if I fall in a heap and get upset about that,
yep.
What sort of support would I have?
Well, it's again one of the reasons why we would like you to come along with a partner or some person that you know and trust. In general, we do our best to preempt that by asking you how you would feel if it happened. And I know it's different when it actually happens. Okay, I appreciate that. But we do our best to try and weed out people who it looks like are really not ready for it. And having said that, we haven't met that many people who are not ready for it. Most people would say, I've got it, if it turns out that I've got it, to be a bit simple about it. And the fact that I now know means I can do something about it. Most people are pretty positive about it. So I don't know about you, but we'd find out if you come along to the study. Now, last question.
Yeah, just a quick follow-up to that one about the cholesterol. Does that mean that the new antibody acting on the amyloid is somewhat analogous to statins acting on cholesterol?
Okay.
I'm on statins because I had a heart attack a few years ago.
Okay, so the question is the solanezumab treatment analogous to lowering blood or serum cholesterol in terms of the effect on amyloid? Well, yes and no. The aim of the anti-amyloid treatments is to reduce the amount of amyloid in the brain. And there are a number of ways you can do that. You can clearly remove it. That's what the antibodies are designed to do. Or you can decrease its production. In general, we would think removing it is probably a better strategy. But as I think I tried to say, in the future, it may be that we use two strategies. We use both removing it and at the same time reducing or stopping production of it. The cholesterol story is more of a longer term, reduce the production of amyloid, if it works. And we don't really have any direct evidence that that's the case. Having said that, the study on Lipitor was done before we had amyloid imaging. So there are some people in the world are thinking we maybe should do that again at some stage. But this is much more promising at the moment. So that's what we're going to focus on. All right. So do you want to close up, or I can close up? Thank you very. We'll hang around for a bit if other people want to ask questions. But thank you very much indeed for coming.